All right. Well, late good morning to you, and I guess I'm the one thing that's standing between you and lunch at this point. Oh, tough act. Okay. I'm not as politically correct as some of my predecessors about our name changes, but as you can see, there's a common theme about our frustration with it. It's just one sign going up and another one being pulled down after the next. And I don't know that's what our next logo is going to be. Apparently, that's for, I think, American University, but it has AU in it. It's going to be something like what we're going to get. Whatever. So, head CT scan reading made easy was the topic that I was asked to cover. And I'd say most of you are probably quite used to simply getting a radiology report that says, here's the results of the CT scan. That's all fine and dandy, but, what is the history that the radiologist usually gets? It's usually what? Syncope, headache, chest pain, and you forgot to mention the other part about the syncope or whatever. Not dense right hemiparesis in the upper extremity, greater than the lower extremity, to tell a radiologist where to be focusing their attention, so they miss stuff based on the limited examination that they get, which is none. So CT scanners have come along a little bit from the old CT scanners, but I thought this was just kind of fun, just the history of the CT scanner back in the early 70s. Two guys, Hounsfeld and McCormick, developed a CT scanner just for doing the head. This was their early prototype. And it gave you wonderful CT scan resolution. I mean, stuff that you could really do lots with. Yeah, not so much. But the technology has obviously improved quite a bit. We now have newer CT scanners that are very high resolution, super duper fast. I mean, these 640 slice CT scanners that have the fixed array, multiple targeting places with the electron beam that's zipping around as you just do a helical scan, and basically can do a CT scan of the beating heart within 1 second and take a look at the coronary artery bypass grafts to see if they're patent as you're watching the flow move through that vessel. It's incredible, the resolution of that stuff. So, but someone's got to read the scan, and I like looking at all my own CT scans. We have a teaching institution, so a lot of times I get a resident read, so it may not always be accurate, and I know what I'm looking for, and they may not know what I'm looking for. Without belaboring this, you do have to know a little bit something about Hounsfield units. If you're looking at your CT scans, it's kind of done for you largely because you can do certain presets. You can do a bone window, you can do a fat window, you can do a muscle window, you can do a lung window, whatever relevant to the body part that you're looking at. And there's also a brain window as well as the bone window because you look at both. Because sometimes there's more than one thing going on. The patient has a stroke and falls and smacks their face on the ground and has maybe lots of facial fractures. So if you only look at the brain window, you're going to miss the facial fractures. So different attenuation windows are going to give you different results, and it's all all the same slice, just different windows. You can see that there are different things that you're going to pick up on based on that. Okay, so you decided I'm going to spin this patient's head, and if you're reading by yourself, then of course you need to do those basics that you learned maybe as a medical student or early in your training. Make sure that you got the right study. Is it on the right patient? Is it the correct date? I've had all these errors happen to me, and because I'm a little more anal about that stuff, I've picked up on it, sometimes a little later than I wanted to. Make sure that you're looking at it correctly. You got to turn correctly if you're using the hard copies, but everything's moving on to digital, so it's kind of taken care of largely. But if the clinical picture doesn't fit the images that you're seeing, there's probably something wrong, and it's probably the wrong study. Okay? Arrow through the head versus nails. I hope that's a cadaveric experiment. That's pretty awful. Or gunshot wound to the head. Okay, so you got the right scan, and you got it turned all correctly. Now how do you start? Right? So much stuff to look at in so many in the series. It's not just single chest X-ray done. You got to do all that. So I'm going to go through a system that's out there and give credit to Dr. Perron, who published this quite a while back. I've made some of my own edits and added my own images to this. But it's a very simple mnemonic that you can remember. Blood can be very bad. Usually is, right? If it's not in the right place. So with that mnemonic, you're going to take a look at CT scan and look specifically for blood. You're going to look at these cisterns. You're going to look at the brain tissue itself, looking for symmetry and some other things. You're going to look at the ventricles and finally look at the bone. And when you've done all that, you're done. Easy, right? Okay. So we'll go through lots of images here in this next section. I'm glad we've got the lights turned down a little bit. So for that first piece, blood, we're going to look for epidural hematomas, subdural hematomas, interparenchymal bleeds, interventricular bleeds, as well as the subarachnoid hemorrhages, the other stroke. Okay, so let's just jump right into that. with lots of images. In the original version of this, it's just normally about an hour-long lecture. I don't give the answer at the top of the slide. I make you think about it, but we're not going to have time for that. So epidural hematoma. Let's see if I got a pointer. Yes. So we have a beautiful lens-shaped hematoma here. We're not going to have time to go into histories on patients. So this is one of these doorway diagnoses. You just kind of throw the image up, the representative image. Boom, there it is. This is what it is. Move on. Okay. Maybe a little hint of some mass effect. The ventricle's a little collapsed over here on this side. So epidural hematoma with a little bit of midline shift. Versus subdural hematoma, which is that long sickle-shaped hematoma. They're along the edge of the skull. Under the dura, hence its name, subdural, probably tearing the Bridgen veins. Elderly patient who's fallen, looks like there's lots of atrophy on the CT scan. And loss of the ventricles on that side because of the mass effect. Might actually have not too many complaints. Might have a little depression of his mental status. You're going to do septic work on this guy as you're doing your CT scan, and boom, there it is, lo and behold. Then you're going to call your neurosurgeon who's going to complain, I got a whole lot of midline shift, not going to do anything, admit him to neurology. And I'll see the patient again in the morning. He needs another CT scan in 12 hours. Okay. We know how that goes. How about this one? Well, the answer's at the top. So we have a chronic subdural hematoma versus, in addition to an acute subdural hematoma. Now, how do we know that? Acute blood is bright white on the CT scan. It's just what it does. It's just bright white. As soon as it clots, it turns bright white. So that's all this bright white stuff. But clot breaks down. It doesn't stay there forever. It breaks down. But in the meantime, the brain stays deformed because that clot's been sitting there so long. So you end up with what's a lot of times called cystic hygroma, or the chronic subdural, which is this black thing. So a few days ago, this guy had this big black thing here from a fall where they got subdural hematoma, I don't know, months, years ago, and now he's bled back into it, and blood layers out because he's been laying with nose up, back of the head down, and it's just layered out. And when you get CT scan, you see this beautiful meniscus, the blood's layered out, and the old subdural's there. Easy peasy, right? Take another one here. Sometimes the subdural will move along slightly different paths. So here it is along the skull, but it's also moving along the falx. So there's hematoma on this side, but not on the other side. A lot of this ends up being kind of pattern recognition. Once you've seen it, you'll recognize it again. If you've never seen it, kind of describing it in a textbook, and if you've seen the picture, it's like, hey, this reminds me of something I've seen before. I need to look a little closer. Yeah, I can figure this out. All right, a parenchymal bleed. So blood right into the tissue. So we're looking at the brain tissue, and white is bad, and there it is, big bleed. A little bit of mass effect. The ventricle down here and the posterior horn is gone. And here's another bleed. This one is extending on into the ventricle itself. These bleeds will sometimes do that. They just don't have enough room in the tissue. Looks like there's actually a little bit of edema around it as well, and he's spilling on into the ventricle. Fair amount of midline shift there as well. And you're supposed to be able to get copies of all these things afterward, somehow. Maybe part of that YouTube thing. So if you're not catching it quick enough here today, you can always go back to this again. And anything, you can always Google it. If you're not quite sure, I've heard of this at least before. Let me see some of the additional representative images. Mr. Google is always very, very helpful when you do an image search. Okay, so here we have blood inside the ventricle itself. I mean, it's packed full. This person's going to need a drain by the neurosurgeon. He's going to have a very small target to hit because all this blood's going to clog up the rest of the drainage system of the CSF. So they're going to build up intracranial pressure massively. So this is quite ominous. From a parenchymal bleed here posteriorly. And again, there's some edema there in the tissue of the brain itself. All right, more blood. This happens to be in the suprasellar cistern. We're going to come to the cisterns in a minute. This is a very obvious one. You see a nice big starman or starfish sitting in the middle? Bright white? Bad, okay? And what lives in this territory? The circle of Willis lives right here. That's where all your aneurysm, or most of your aneurysms appear from. So 75, 85% of the time, folks have aneurysms that are bleeding. That's the location. That's where you're going to be looking first if you're thinking an aneurysm will bleed. And as soon as you flash the CT scan and you see this, the starfish, and then the CT scan's like subarachnoid hemorrhage. We need to go to whatever arterial study you do at your facility. MRA, CTA, arteriogram, whatever they do, whatever your neurosurgeons are used to and your radiologists are used to. Don't forget to look outside the brain. So in this case, big scalp hematoma here, right? You probably picked that up on clinical exam as well, but just don't forget to look at it, and then you're going to be interested in doing the bone windows to see if there's a skull fracture underneath there. Okay, so that's blood. So let's move on to the cisterns. So cisterns are these fluid baffles that we have inside of our brain. Just places where fluid moves on through as it's making its circulation around the brain. It's a little bit different from the ventricles. We'll come to ventricles when we get to V. And there's 4 cisterns that we need to take a look at. I think we couldn't squeeze any more letters into that word: circummesencephalic, the suprasellar, the quadrigeminal, and the sylvian. So let's take a look at some examples here. So the circummesencephalic, it is way down here toward the bottom. It is this ring around. A lot of folks will describe the brainstem here as looking a little bit like a heart with a notch on the bottom. Okay, so we're taking a look at that area. So let's do this here without. Here we go. The circummesencephalic cistern, and let's take a look and see what it looks like with blood in it. Looks kind of like this. All right. Here's where we're looking. There's also a little incidental blood here in the sylvian fissure, somewhere here in the midline fissure, and here, since they're so close to each other, the suprasellar cistern and the circummesencephalic cistern, we've got blood in both of these. Okay, circummesencephalic. So next is the suprasellar cistern. Remember we talked about the starfish just a second ago? So you can kind of see it not filled with blood here. Kind of imagine this little pentagonal thing in the center. And when we put a little blood in it, this one's a little harder to see. Okay, so you have to be careful. You can't just go, blitz through the CT scan, done. Now, you need to look at it a little bit harder than that. But can you appreciate that? Okay, if you're going fast, you might miss it. Right? All right, next is the quadrigeminal cistern. It's kind of a W-shaped. You can make out that W. And when it's filled with blood, looks a bit like this. And we'll get to the sylvian fissures here in a second, but there's a little bit of blood here in the sylvian fissures. So there are the sylvian fissures right there along the temporal lobe. And there's some blood in those. Good. All right, that's our cisterns. Next, we've got brain matter itself to look at. So we're going to look for symmetry. We're going to look at something called effacement, midline shift. We kind of alluded to that already a couple of times. Hyperdensities, hypodensities, and pneumocephalus. So let's jump right in. Is it symmetrical? Yeah, it is. Is it normal? No, not really, right? Not a whole lot of brain matter left there. Some huge ventricles, lots of atrophy here between the gyri of the brain. Elderly patient, clearly, it's probably a ventricular shunt that he's got in place from long-standing hydrocephalus. It only did so much, but you're going to have to figure that out with the rest of the picture. What's going on here? Why did I get the CT scan? Am I concerned? Maybe it's for shunt malfunction and there's worsening hydrocephalus compared to a previous CT scan. Okay, symmetry. Well, the story's at the bottom. That kind of clues you into what you're looking for. What do you think? Is that symmetrical? On first, just a quick glance, yeah, it's symmetrical. Wait a minute. There's kind of some hypodensity going on here, and there's something hypodense here. Oh, there's a big area of hypodensity over here that doesn't look like that side. So this person's throwing emboli from his heart, from his previous stab wound, into his brain. He's just showering his brain regularly, infarcting different sections of it. So that's not a normal CT scan. You have to look close. More symmetry. What do you think? I'm going to give you a second just to look at that. There's brain there, yeah. It's kind of gray and fuzzy, yeah. But if you look close here, you can see there's all kinds of little lacy, fine, little gray, white patterning in here. And over here, this side, that's just a big old gray blob. Over here, same thing. Big old gray blob. Whereas here, you can see nice gyri. You can see gray-white interfaces. So this side over here is abnormal. There's a tissue edema here from an ongoing infarct. This is bad. And 24 hours later, that same patient is looking like this, and it's a little bit easier to see now. But early on, it kind of gives you the clue. There is a huge infarct here. This person's going to do very terribly. Probably got a big middle cerebral artery infarct, and he's going to lose a third of his brain. Okay? And as you can see here, the mass effect that it's causing at this point. The ventricles collapsed, completely gone on that side, and the tissues on that side are being pushed over. You know, there's not a whole lot to do for this person. It's going to be heroics. Kindest thing you can do, elevate the head of the bed and start talking to the family about final preparations. Or if it's, you know, all gung-ho, then the neurosurgeon might be talked into taking the top off and letting the brain swell. But they will not do well. Okay, so we mentioned a subdural hematoma a little while ago. Is this an acute subdural hematoma, a chronic subdural hematoma, or? It's not bright white, is it? Oops. Crap. There. It's not bright white, so this is not acute. This has been going on for a while, but it's not to the density of cerebral spinal fluid. It's not gotten to that point yet. So this is probably a week or two old. It's now hypodense compared to the rest of the brain tissue, but it's not completely liquefied yet. Okay, and there's considerable midline shift. It's amazing how, you know, I'm in a good position, and there's a couple of other gray-haired people here. If we whop our head and have a subdural, we'll tolerate it quite well. Whereas you youngsters, you're going to go down the toilet immediately because you don't have room in your brain, inside your skull, to accommodate that hematoma or mass effect. Us old folks, we got some atrophy going on. We can hide it for a while before we decompensate. Okay, and I'm feeling good about that. In 5 minutes, I won't even remember that I said that. It's even better. These patients may not present with much, or they're a little confused. It wasn't so bad, so we kind of thought we'd watch it for a while. And then something else happens, and then they finally get brought, and then it is incidentally found. It's like, oh, crap. Right? So if it's been going on for a while like this, the neurosurgeon may say, yeah, we're going to continue watching it. We're not going to start drilling holes in there to decompress that. They're tolerating this joke quite fine. It didn't kill them right off the bat, so let's leave them alone. That's what Dr. Scheiber was alluding to earlier about you don't always want procedures done. All right, nice brain abscess with midline shift. Lots of edema around that. Maybe the patient's presenting with new onset seizures. You can have pretty large tumors inside your brain before you start having symptoms of it. That's always the sneaky thing with those tumors. Here another brain lesion with vasogenic edema around that. Mass edema. In pneumocephalus, maybe the patient's complaining of lightheadedness. Bad joke. Maybe traumatic incident, or maybe they had lumbar puncture done using air as a contrast instead of some other contrast medium. Plenty of headache. Okay, we move on to the ventricles, V. So we're going to take a look at several of our ventricles, and there's several things we're going to look for in each of those. Keep moving along here. So here's a cast of the ventricles. I always think it looks a little bit like Alien, Alien versus Predator. I don't know, maybe not. But the ventricles kind of are difficult for me to wrap my brain around, no pun intended. They're just hard to conceptualize three-dimensionally for me. There's another representation. Pretty. I might hang it on my wall just for artwork. Okay, so some folks will describe the lateral ventricles as the back-to-back commas. So comma, comma. So you're at that level, and obviously above and below a little bit. So we take a look at those, and do those look symmetrical? Yeah? Is there something bright white in there? Yep. Is it blood? No, that's an old calcification from the choroid plexus. You don't want to remove those because that's what makes your spinal fluid. If you remove those, your brain's going to be mighty dry. You will not like that. Okay? And here's more calcification in the lateral ventricles as well as here in the pineal body. If you're not used to reading these on a regular basis, they're going to alarm you. I've seen some patients get transferred for those, and it's like, oh, you have normality, you can go home now. So just be aware that those are there. Fair amount of atrophy on that brain. Quite a bit of atrophy on this brain. Okay, so these are the lateral ventricles again. I'm not sure about opposing commas. This is more like opposing water balloons. Very large, clearly. All right, well, the clue is there, but you have to tell me where the hemorrhage is. Someone says on top? You're seeing hemorrhage up here someplace? probably blood from here because this is a little bit wide in the third ventricle. We've got our choroid plexus and the pineal body, but then we've got these little menisci down here, and that's blood that's laying in the posterior horns of the ventricles. Okay? So don't always look at the center, look at the periphery as well. All right? Lateral ventricle is collapsed. Okay? It's clearly not symmetrical. Why? Why is that ventricle collapsed? Look hard. Yeah, some folks are saying it. Look closely here. There's a line right there, and everything here is kind of a uniform gray, whereas here is kind of the normal gray matter with some gyri in it. This is a huge subdural hematoma, gigantic subdural hematoma. It's isodense. It looks the same density as brain. This one's easy to miss if you're not paying attention. Okay, you just it's like, oh, wait a minute, where's the ventricle? And what's happening? Something has to be making it collapse. Okay, that clues you in. All right, slit-like ventricles, loss of gyri. This is typically going to be something from diffuse axonal injury, which you'll see with rapid deceleration injuries. So car accident, person versus bridge pillar going 60 miles an hour, where the brain goes from 60 to 0, like instantaneously. Brain doesn't like that, it swells up. You think a neurosurgeon is going to be able to put a ventriculostomy drain in there to check pressures? No. Okay, very poor prognosis. It's like everything in there has been rattled around and jarred and is swelling and going to die in pressure. Okay, now the third ventricle is here in the center. It's kind of the keyhole slit, but not like the slit-like ventricles that we were talking about in a second. This one's supposed to be nice and skinny, sitting right there, and connects the two lateral ventricles to each other. So here's that one that we saw a minute ago, and I said, seems like there's a little bit of haloing around that pineal body, and that ventricle is just a little bit, that third ventricle is a little bigger than it ought to be. That's probably where they bled from, and that's layered out here in the posterior horns of the lateral ventricles. Fourth ventricle is down here. It's kind of helmet-shaped as the CSF is making its way down toward the spinal cord, and there's some blood down in the fourth ventricle. And where else do you see blood? Star, which is called the suprasellar cistern. Excellent. And we're down to the last one already, our fifth component, bone. That should be easy, right? So let's just go right on into that. Bone. Again, windowing is important. So if we're doing more of a brain windowing, you can see it's just kind of a blur, but if we change that, we can make out a little bit more about air and depressed fragments and see much better what's going on here. We don't like thinking about sinuses, but sinuses are good to look at. So sphenoid sinus, here's fluid in the sphenoid sinus. Here is a fracture in the petrous bone, and we've got our ethmoid sinuses packed full of blood, or mucus or pus or whatever. Here's our ethmoid sinuses, here's the sphenoid sinuses. And don't forget about the mastoid air cells. We'll take a look back here. And it looks like this person's got some blood in the sphenoid sinuses as well. Oh yeah, it says on the slide. And you've seen that once before. So penetrating injuries. So don't forget, the clue may be, oh yeah, here's all that soft tissue swelling, and yep, there's the stuff penetrating the cranial vault. A couple of extra special things, especially in doing stroke work. The hyperdense MCA sign and insular ribbon sign. So let's take a look at those. So what do you think about that CT scan? Does it look symmetrical? Yeah, it's symmetrical. Pretty much. See anything bright white? Yeah, there's kind of this little comma thing sitting in there. Doesn't look like much, does it? You're looking at the middle cerebral artery and a clot that's embedded in it. It's completely occluded by clot. Okay? That person is going to lose brain from here to there. That is a third of their brain that's going to get wiped out because that's what it supplies from vascular supply. So this is an ominous sign. This person's going to come in with a high NIH stroke score, about 22, something like that, devastated. And they're going to do very poorly unless treated very aggressively. And TPA is probably not going to handle that by itself. It's too much clot burden. So hyperdense MCA sign. Here's a follow-up CT scan on that same person. Okay, they're going to wipe out that brain. Big mass effect. In fact, looks like they've actually got some spontaneous hemorrhage into the infarct, which happens not infrequently, especially with those large vascular territory strokes. Spontaneous bleed. It's not TPA related. It's just bad tissue, and as it breaks down, the blood vessels break as well. Okay, insular ribbon sign. This one's a little trickier, a little tougher. So there's some arrows that are here a little bit in the way, but you can still see a bit of that lacy gray-white interface, and on the other side, it's kind of smudged out from the early edema that's going on from the stroke. Okay? Just like the effacement that we saw earlier, where that gray-white differentiation took place. Same thing, it just happens to be right there at the insular ribbon along the Sylvian fissure. So same thing here without arrows and different sides this time. Okay, normal versus abnormal. It's just a little prettier, a little cleaner, and a little smudged on this side. You're going to get the symptoms to go along with that to kind of clue you into where to look, and especially if the family says, you know, they were normal an hour ago. It's like, no, this has been going on just a little bit longer. Double check your time of onset. Okay, so we've alluded to already that acute blood is going to be bright white because it clots, and that's just what it does from the Hounsfield attenuation thing. It's going to be more dense. Blood, as it breaks down, becomes progressively more isodense and then finally hypodense. How fast does that happen? Unfortunately, it goes to my favorite answer, which is it depends. It depends on what your hemoglobin is. It depends on how well your metabolic system's revved up, how fast your body's breaking down the clot. Okay, so it's because it's going to depend on the usual stuff that breaks down any clot any place else in your body, the bruise on your thigh or whatever. So depending on how long all that takes and how big the clot is, it's going to move along different paces in different people. But this kind of throws in that general ballpark, the 1 to 2 weeks and after 2 weeks. Picking up blood on the CT scan, particularly subarachnoid bleeds, fairly good sensitivity early on, unless it's just a small bleed, a sentinel bleed. Those may be hard to pick up, and your history is going to be suspicious, and you have to decide whether or not to move on with an LP. And as time goes on, your sensitivity just drops, finally drops like a rock, and it's completely useless. You still get your CT scan, but when you get it normal, it's like, what do we do with that? I've got to do something else. You don't want to just CTA everybody because you're going to pick up the baseline normal about 5% of aneurysms that the population has that are completely asymptomatic. And then now you've got pathology, and now what? Now you move, do we do something about that? Do we observe it? You're going to need more CT scans, lots more radiation. You've opened up a can of worms was that the right thing to do? Have you helped your patient in that case? I mentioned earlier that most of the aneurysms are in the circle of Willis, from the circle of Willis, an immediate adjacent area, so the suprasellar cistern is where you're going to be looking for those bleeds. And with the infarcts, I kind of alluded to it. If you start seeing infarct changes on the CT scan, the infarct is probably 3, 4, 5 hours already in its age. So when people are telling you, it just started 20 minutes ago, it's like, no, there's something wrong with this story. Let's go back and get some more history, because someone's got something confused. Remember, a lot of people, when you ask about when was the last normal, they'll tell you when they found mama, which is not what you want to know. That's totally uninteresting. When was the last time mama was normal? That's what you want to know. Here's a patient with spontaneous hemorrhagic transformation from their stroke, probably about a week out. Okay. So we'll a lot of times warn the folks at a spoke hospital. So if you're planning on keeping this patient, just be prepared. They're probably going to deteriorate very suddenly in a few days. There's going to be a big change. You can rescan them, but don't be surprised when you see blood. And let's prepare the family for that as well, to anticipate that there's a good chance this is going to happen. So there we covered it. Blood can be very bad. Bone, cisterns, brains, ventricles, and bone. So what is this? Kind of last quiz. Suprasellar cistern and? Circummesencephalic cistern. Kind of depends on how the patient has their head tipped a little bit. Head's usually tipped a little bit on the CT scanner, so depending on how much it's tipped and how cattywampus they are in general on the CT scanner, you may pick up other places. So, crap. And we also see blood in the Sylvian fissures. Okay, so this blood's spread out all over the place. So, if you're looking at your own CT scan, if there's no blood, if the cisterns are all open, patent, the brain is symmetrical, there's no bright white spots in it, the ventricles are wide open, no dilation, and there's no fractures, then you can say it's a normal CT scan and you can sleep soundly and your patient can be reassured. I saw yesterday driving in on a billboard, Valdosta is the Azalea City, so for for Valdosta. I put this slide up for hosting us. And that is that.